Welcome to another episode of MTP, or Meet the Penis. Yes, that's what we call it. And today I'm fortunate enough to have with me Dr. Gabriele Antonini. He's a professor at Sapienza University in Rome, and he's my brother, basically. He and I have a very similar history in that we started doing penile implants through a certain approach and moved to another approach. And this week's question, sorry, we have a lot of people running through the operating room right now. This week's question is really good to ask two experts in this, in that this patient, Albert E., I'm not sure where he's from, but he asked that he says he goes on the internet and he sees all types of different procedures and, you know, which one is the best. And we all have our preferences. And today you will have some bias because both he and I like the same approach. But we're going to tell you what we think is good about what we do. And there's basically three approaches that we need to know about. There's the penoscrotal approach, which has been for years and still is the predominantly used approach for penile implants. Then there's the infrapubic, which both Gabriele and I do. And then there's the subcoronal, which is fairly new, and I don't know a whole heck of a lot about it, so we're not going to talk about it that much. But I'd like for Gabriele to first give us his assessment of what he thinks about the infrapubic approach. Gabriele?
Yes. Thank you very much for staying here to my American brother, Paul Perito. I'm very proud to stay here for two reasons. The first one, because I can see the first one, the best surgeon about penile prosthesis in the world, and it's the true. And then because after about 100 penile implant with the penoscrotal approach, 5 years ago I switched completely my technique, and now I use the infrapubic technique. I think this is an error. Speak about the infrapubic. I use the Perito technique because the technique is a series of codified steps that permit to implant the prosthesis quickly and safety. This is the reason that I switched the technique. But the most important is, and this is we have published this 1 year ago, the quickly rehabilitation about the sexual intercourse, because the patient after the procedure hasn't any pain, any discomfort, and no has the incision on the scrotum. And it's the most important thing, because he can find the pump very well, he can touch the pump very well, and he can start the rehabilitation in 14 days. I have some patient that after 20 days has had the first sexual intercourse, and it is awesome for me and for the patient, and I want to thank Paul, because I completely changed my way to implant the prosthesis, and I think it's the best way to do it.
Thank you. I didn't pay him for that, but it was very, very nice of you to say. But and he actually misspoke, because he meant to say that he recently had a patient who at 12 days, 12, not 20, at 12 days was already initiating sex, because that incision is so far away from any device components, and because the incision is not an obstacle to your rehabilitation, you're able to work the pump and get it going and get back to your normal sex life. So, two biased approach, two brothers. Of course, we're going to be on each other's side. Go ahead and look through the internet, and you can make your own decision on which approach you think might be best for you. In reality, when done correctly, a year down the road, all approaches should be equivalent. So today, thank you, Albert, for asking the question, and because my brother was here in town. We actually were in Lisbon last week speaking. It was just a perfect timing for me to have a biased expert opinion. Thanks again. Bye. Next week.